Median nerve arises from C5, C6, C7, C8 and T1. No branches before elbow, between two head of pronator teres at the elbow. 5 to 6 centimeter distal to the elbow gives off anterior interosseous nerve, which is motor for deep flexor muscle, that is FPL and FDP. Index finger FDP and pronator quadratus. Median nerve proceed between the FDS and FDP. Give palmar cutaneous branch, which is sensory to thinner muscles, arises 5 centimeter proximal to the wrist joint and overlies flexor retinaculum. Enter flex carpal tunnel between palmaris longus and FCR. Give recurrent motor branch to the thinner muscles, arises at distal end of carpal tunnel. The motor supply is for pronator teres, flexor carpi radialis, palmaris longus, FDS, and loaf muscle. Two radial lumbricals, opponens pollicis, abductor pollicis, and flexor pollicis brevis. Anterior interosseous nerve supplies flexor pollicis longus, radial half of FDP, radial 2 FDPs, and pronator quadratus. Sensation 3.5 digits. Autonomous zone tip of the index finger. When you're examining, a thinner sensation loss means high lesion. Differential diagnosis: cervical radiculopathy, spinal cord lesions, tumors, multiple sclerosis, syrinx. Peripheral neuropathy, vitamin B12 and folate deficiency, toxic, alcoholic, uremic, or diabetes mellitus. Median nerve compression test: 86% sensitivity, 95% specificity. Elbow extended, forearm in supination, wrist flexed to 60 degrees with digital pressure applied with one thumb over the carpal tunnel. Test is positive if paresthesia is developed or numbness within 60 seconds. This is called Durkheim test. The anterior interosseous nerve comes off the median nerve between two heads of pronator teres, 4 cm distal to the medial epicondyle, exits from anterolateral aspect of the medial nerve, runs in front of the interosseous membrane in the interval between FPL and FDP, terminates distally in pronator quadratus and the wrist joint. Potential sites of anterior interosseous nerve compression: DFAT, deep head of pronator teres, FDS arcade, edge of laceratus fibrosus, accessory FPL, Ganser muscle, or thrombosed radial and ulnar artery. AIN supplies FDP except the ulnar FDP, which is supplied by the ulnar nerve, flexor pollicis longus, and pronator quadratus. There is no sensory branch. Presentation: Benedict hand due to the paralysis of FDP of the index finger. Pronator quadratus weakness tested in pronation in flexed elbow. Flexed elbow neutralizes pronator teres. Treatment: splint 9-degree or surgical decompression. Martin-Gruber anastomosis branches from median to ulnar nerve in forearm. Result in median nerve innervating number of intrinsic muscles of the hand. Distribution of the ulnar nerve above anastomosis may not result in the motor loss. Pronator teres syndrome. Pronator teres syndrome is a compression of the median nerve at laceratus fibrosis, that is high origin of pronator teres. This is tested with resisted pronation with elbow extended. Pronator teres muscle, tested pronation with elbow extended. Fibrous arcade of FDS, resisted flexion of PIP joint of middle finger. Resisted flexion of PIP joint middle finger, or ligament of Struth, band from the anterior supracondylar spur, present in 1.5%. Aching of the forearm with heavy use, clumsiness, vague intermittent pain. Sign: local tenderness to deep pressure and reproduction of pain. Tinel test: positive. Pain in resisted pronation of the forearm with elbow extended for pronator teres. Pain on resisted elbow flexion and supination laceratus fibrosis. Pain on resisted finger PIP joint flexion of middle finger FDS arch. Nerve conduction study is not of any much use. EMG may show evidence of reduced innervation of muscles, may differentiate from carpal tunnel syndrome. Management is conservative. Avoid repetitive trauma. NSAIDs: splint with elbow flexed and pronated. Surgical decompression of all the muscles. Anterior interosseous syndrome: compression under the humeral part of the pronator teres. Anterior interosseous nerve is a motor to FPL and radial side FDP and pronator quadratus. Does not provide any skin sensations. Efferent sensory branches from capsular muscle structures to the wrist and ridge. Clinical diagnosis: vague pain of the forearm, reduced dexterity, weak pinch, unable to do OK sign, weak pronation with elbow in full extension for isolated pronator quadratus. Direct pressure over the nerve elicit pain. Treatment conservative. NSAIDs: avoid aggravating symptoms. Surgical explanation: most common complex structure is the deep head of pronator teres.